Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Principal PKDAS Institute of Medical Sciences. In the last session, we have discussed about the adrenergic receptors, the alpha receptor and beta receptor. Today, I will be discussing about the alpha adrenoceptor antagonists or alpha blockers. Just recap. The sympathetics arise from the intermediolateral horn cells. They rely in the paravertebral ganglia, and from there it goes to various organs, second order neurons. And the neurotransmitter is norepinephrine. In the eyes, it acts on the alpha receptor, produces mydriasis or pupillary dilatation. In the lungs, it acts on the beta receptor, the beta 2, and produces bronchodilation. In the heart, it acts on the beta 1, produces increased heart rate and increased force of contraction. In the blood vessel, it acts on the alpha receptor. It predominantly produces vasoconstriction. In the gastrointestinal tract, in the uterus, and in the bladder, it predominantly produces relaxation. And in the bladder, it is important to remember that in the detrusor, it is beta receptor, and in the internal sphincter, that is in the urethra, it is an alpha receptor. Alpha receptor produces contraction. So what will happen when the alpha receptors or the bladder is stimulated? Alpha receptors are present not only in the internal sphincter but also in the prostate gland. The prostate contains glandular tissue and the stroma which contains the muscle. The muscle contracts and what will happen? The urethra will be squeezed. And that is why the continence is preserved. So these are the minimum things you should remember before going into the actions of the alpha blockers. Now, once more think about what are the alpha receptors. Alpha receptors are predominantly two types. One is the alpha 1 receptor, second is alpha 2 receptor. Subdivisions are there still. Just remember that the alpha 2 is predominantly in the presynaptic ending of the neurons. So, the synaptic vesicles contains norepinephrine that is released in the synaptic cleft, a part of which is reuptaken, and it will stimulate the alpha 2 receptors there. The alpha 2 receptors produce a negative action, that it will inhibit the release of further neurotransmitters. So that is how the alpha 2 acts. So alpha 2 acts as a check, that is excess action of the release of the norepinephrine will be blocked by the activation of the alpha 2 receptor. Now we go to the alpha 1. Alpha 1 is predominantly in the blood vessels. It produces vasoconstriction. In the eyes, already I have mentioned, it produces mydriasis. In the prostate, it acts on the alpha receptor, produces contraction and it helps in ejaculation. And also helps in continence, that is, it contracts the internal sphincter. At the time contraction of the prostate, both produces squeezing of the urethra and the urine is held there. Alpha receptors are further subdivided into the alpha 1 can be alpha 1A, alpha 1B and alpha 1D. Alpha 2 again divided into alpha 1A, B and C. So there are subdivisions of alpha 1 and alpha 2 also. This is here which is again shown when the norepinephrine that is released is reuptake, activation of the alpha 2 receptor, a negative feedback, and norepinephrine is not released. And the action of the alpha 1, it is on the vascular smooth muscle. It produces constriction or contraction by different pathways. Now we go into the alpha blockers little more. Alpha blockers are basically divided into two types. One is the non-selective and the other is selective. What does it mean non-selective? Non-selective means it blocks both alpha 1 and alpha 2. Selective means it specific either alpha 1 or alpha 2. So that is the difference. The non-selective drugs are limited. Two drugs you should remember. One is the phenoxybenzamine, and second is phentolamine. phentolamine. These drugs are not routinely used. They are used for the treatment of pheochromocytoma. That is something you should remember. That is the management of pheochromocytoma. Use the non-selective alpha blockers. Alpha 2 blockers are not very useful clinically and their use is limited. Just remember the name yohimbine and edoxaban. So these are the two drugs that you should remember. The more important is the alpha 1 blockers. Alpha 1 blockers are usually they end with the osin. So that is how you can easily remember. So they are prazosin. You can see the sin, prazosin, terazosin, osin is there, doxazosin, osin is there. An important drug you should remember is tamsulosin. Alphazosin. Newer drugs are there. Sildosin. So just remember terazosin, doxazosin, tamsulosin, sildosin, prazosin, alphazosin. Again, these drugs have little more specificity. This tamsulosin and sildosin, sildosin and alphazosin, they are uroselective. Remember this term, uroselective. What do you mean by uroselective? They act mainly in the urological sites. We have said about the bladder, the prostate and the internal sphincter. It is because of the selectivity of the receptors. The alpha 1A subtype is predominantly seen in these regions. Alpha 1B is in the blood vessels. So if the selectivity for alpha 1A is more, it will be more uroselective. The capacity of sildosin is 160 times more to block the alpha 1 receptor compared to alpha 1B. So that is why they are more selective. So tamsulosin, sildosin, alphazosin, these are uroselective. You remember that. So this is the basics of the regarding the selective and non-selective types of alpha blockers. Now we will look into what are the uses. Uses are limited. Most important use is in benign prostatic hypertrophy, about which we will study later. The pheochromocytoma I have already told you, and in some cases of hypertension. It is not a preferred drug for management of hypertension. Only when there is a confounding condition like prostatic hypertrophy is there, you will use the drug. So it is usually considered as a second line drug rather than, so it is a second line drug, not a, because it has got many side effects. Now going to the mechanism of action of these alpha blockers, they act as predominantly competitive inhibitors. What do you mean by competitive inhibition? Competitive inhibition means this is the receptor site and this in the receptor site, this alpha blocker will occupy that site so that norepinephrine cannot act. This is a basis. So this is a take a receptor, and this is the norepinephrine. Exactly it has to join there, but something is occupying that region so that the norepinephrine cannot activate that receptor. This is the basis of the competitive inhibitor. All these drugs are competitive except phenoxybenzaimine. Remember that, phenoxybenzaimine. So what is the peculiarity? It acts on another site, an allosteric site. So it produces what is called a allosteric inhibition or allosteric site. It is active, it is attaching, that will produce a conformational change in the receptor site. So the receptor site get modified so that the substrate or the norepinephrine will not be able to attach there. So what happens? This will be usually an irreversible inhibition, a long lasting. So phenoxybenzaimine is a long lasting action, and if you take the comparatively the phentolamine, it has a short duration of action. So during surgery of pheochromocytoma, you use the phentolamine for when there is a crisis, hypertensive crisis occurs, or somebody taken cocaine and comes with a hypertensive crisis, again you can use the phentolamine. So that is regarding phentolamine. Phenoxybenzaimine on the other hand, it is an irreversible inhibitor, long lasting, long action is there. So preparation of patients with pheochromocytoma, you give phenoxybenzaimine. Hope this point is clear. Again, just remember that these are acting via G protein coupled receptors. The mechanism of G protein coupled will be discussed in another session. So the mechanism of action, somebody asks you, you should say it is a G protein coupled receptor activation leading on to the contraction of the smooth muscles. That is the mechanism of action of the. Okay. Now we go into the therapeutic uses. Already mentioned pheochromocytoma. There is a tumor arising from the adrenal. This is the number one use for the non-selective ones. That is the phenoxybenzaimine and phentolamine. The details we have already discussed. The selective alpha-1 blockers are very useful in management of patients with the lower urinary tract symptoms due to benign prostatic hypertrophy. So here you can see the urethra, the internal sphincter. Here is the external sphincter. The prostate gland will be coming here. So somebody with a lower urinary tract symptoms due to the benign hypertrophy of the prostate, the transitional zone is hypertrophied. This will squeeze the urethra and will prevent the passage of urine. So what will happen? The urinary stream becomes thin. Patient will have difficulty in passing urine. The bladder get irritated. So there can be frequency infection and other things can follow. So, and I already mentioned the commonly used drug is tamsulosin. It is given as 0.4 milligrams. Many of these drugs can produce postural hypertension, so better taken at night. So tamsulosin 0.4 milligram is a commonly used drug. For hypertension, we give prazosin, especially if the patient has got a benign prostatic hypertrophy. The dose used is less than 10 milligrams, usually 2 to 10 milligrams. Doxazocin can also be given. The dosage is usually 1 to 8 milligrams. Again, remember this is given only when there is as hypertensive, antihypertensive drug if the patient has got benign prostatic hypertension and is not the first line drug. It is usually used as a second line drug. Hope these points are clear to you. Again, we have mentioned the common drugs. Just recap: alpha blockers, selective and non-selective, prazosin, terazosin, doxazocin. Remember tamsulosin, sildosin. Other drugs are also on the pipeline. Non-selective, remember phenoxybenzaimine and phentolamine. Phenoxybenzaimine has long-lasting action. It's a non-competitive inhibition. So the half-life is 24 hours, T-half. And phentolamine is a short-acting hypertension caused by pheochromocytoma or cocaine abuse you can use. And prazosin is the prototypical drug for alpha-1 blockage. It can be given in essential hypertension. Half-life is 12 hours. Now we look into what are the side effects, mainly for non-selective alpha blockers, but we can get some of them in the selective alpha blocking also. So alpha blockers, the main action of alpha blocker is alpha stimulation is vasoconstriction. So when the alpha blockers are given, what will happen? There will be vasodilation. This vasodilation leads on to decrease in the peripheral vascular resistance, and it will produce reduction in the blood pressure. So that is why it is used as an antihypertensive. When the BP is low, what will happen? The baroreceptors will be stimulated. So when the baroreceptors are stimulated, it gives impulse to the medulla and the adrenergic activation occurs, and you get reflex tachycardia. So tachycardia due to baroreceptor activation is one of the side effects you can get. At the same time, this reduction in the BP can activate the renal juxtaglomerular apparatus. It will lead on to release of renin, leads on to develop aldosterone, and this aldosterone will produce fluid retention. So one of the other side effect will be edema formation. By giving diuretics, you may be able to control it. So we have mentioned postal hypotension is very important. It can produce tachycardia, and the nasal blood vessels are dilated because alpha blockage produce nasal blockage of the constriction of the nasal blood vessels. So it can produce nasal congestion. The prostatic contraction is by the alpha receptor. So when the alpha is blocked, you can get reduction in the ejaculation. And sometimes as the internal sphincter gets relaxed, so you can see here comes the prostate, and the seminal vesicles are, the vas is coming joining here. So what will happen when the internal sphincter is relaxed? The semen may go retrograde. So this can produce retrograde ejaculation. Headache is a common complaint. It is due to cranial vasodilation. So these are the major side effects of non-selective alpha blockers. Some of them will be present in the selective blockers also. And again, one more thing you should remember, that is when you are using non-selective beta blockers, for example phentolamine or phenoxybenzamine, it blocks the alpha-1 receptors. At the same time, it blocks the alpha-2 receptors also. I have told you the alpha-2 receptor stimulation leads to reduction in the release of norepinephrine. So here what is happening? The alpha-2 is blocked. So there will be excess release of norepinephrine. This can lead on to a reflex tachycardia. So tachycardia is a common problem when you use non-selective alpha blockers. The prototype of selective is the prazosin. It is alpha-1 selective. It will not inhibit or block the alpha-2 receptors, so the norepinephrine release will be blocked. So when the norepinephrine acts on the alpha-1 receptors, it produces decrease in the blood pressure. So you can get a hypotension. If hypotension occurs, it can activate the baroreceptor. So compared to non-selective alpha blocker, selective alpha blockers produces less incidence of tachycardia. So reflex tachycardia is a major feature of non-selective alpha blockage. Another important side effect you should remember is the intraoperative floppy iris syndrome. We know that the alpha receptors are there in the dilator pupillary muscles. So when these muscles are getting relaxed due to alpha blockage produces relaxation of the pupillary dilator fibers. So what will happen? The pupils become constricted, it becomes floppy, and through the incisional site while during cataract surgery, this may come out also. This is the intraoperative floppy iris syndrome. Tamsulosin is even usually in patients with benign prostatic hypertrophy. They are elderly and they can have cataract also. So while doing cataract surgery, this point to be kept in mind. So today we have discussed about the alpha blockers, the subgroups of alpha receptors, the action of the alpha receptors, the side effects, and the precautions that will be taken while using alpha blockers. Hope this was useful to you. Stay tuned for further videos. Thank you.